like to start with a short little question round directly to our panelists, whom I greet. I'm happy to have you here. Let's start with Amanda. Amanda, what can family doctors do in this large, broad topic?
Thank you very much. Good morning, everybody, and the World Organization of Family Doctors, which has members all over the world and struggling, of course, with this issue. We're very delighted to be contributing to the meeting, and congratulations on hosting it. You've said briefly, so I think that where we're seeing good practice, and the Ghanaian example, which I also had learned about when I was there recently, is one. It's a combination of public education. So we can do that in our own communities and clinics. It's very helpful when there is a good evidence-based media campaign as well, because then it's easier to have the conversation with the patients and the community. If you say, you know, the drugs don't work anymore so well as they did, people are saying, oh yeah, I heard about that. So public education, professional training, of course. So we, the GPs, the nurses who are working with us, the other health professionals in the community, all need to understand what best practice now looks like. The third thing, I think, is restriction of over-the-counter sales and what I would call excessive protocol-driven antibiotic prescribing, because you really do need to make the right diagnosis and only use them when it's necessary. Point-of-care diagnostics may come in and help us at the moment. I still don't have very good availability of that in my community, and I'm in a developed country, but that may be the future. Peer comparison, you know, in some countries we get data, we get feedback, and if you're an outlier on the prescription rate, that may be legitimate because it's the clientele you happen to be looking after, but at least you're asking the question, why is my clinic or why is my practice giving so many antibiotics compared to people close by. Tailored risk groups, so I think getting more evidence about who really needs and who doesn't, sort of checklist guidelines work. And then, of course, helping with research. So we're, again, getting information. You can give a shorter course. It doesn't need 5 days, it only needs 3. These kind of evidence-based. Now, many countries do not have that level of availability. So the only other thing I wanted to say is, where are some of the barriers? Of course, if you don't have skilled clinicians working in the primary care setting, if people are having to bounce in and out of emergency clinics or buying their own or going to the hospital, and also where people are very overworked. So of course we know that if you have 3 minutes for the patient, it's easier, isn't it, to just give the penicillin and go, rather than have the conversation about how maybe this is a virus and these are the things you must watch out for. And second thing is continuity. In my place, in some systems, I can ask the patients, come back if your child gets worse. You know, look for this, you can come back. If they've already paid $20 or $30 to see me, they don't want to have to wait 2 days and come again. And they also think, why is the doctor saying that? Maybe she just wants another fee. So I think pay out of pocket is a barrier sometimes to good practice. Lack of continuity. If you have an effective primary healthcare team that you trust and you're registered with them, then you say, okay, yeah, they're good, we'll go back if we need to, no problem there. And if you think this doctor's just after some money, or the other way, I've heard colleagues say, I felt I had to give because otherwise they'll go to the GP down the road next time. So I think the health system can help us with good practice. Good training, as I say, and of course sometimes mixed messages in the media can also not help us. So is that enough to start with?
I think thank you very much. I think it also shows how broadly involved you are, and I think it is also the case for the nurses, and that's why I would like to give over directly to your neighbor, who also is, like you, very broadly involved into the question. And thank you for alluding to healthcare systems and their influence on your work, because there is a plus-minus determination.
Please remember, the picture of modern family medicine is very different in different parts of the world. So that's also a challenge, is to get the right workforce for strong primary health care across the globe.
Good morning, everyone. Thank you very much for the invitation. It's great to be here. I am a nurse. I haven't practiced for a little while, but before coming to Geneva, I worked for the Royal College of Nursing in the UK, and I now work for the International Council of Nurses, which is a federation of over 130 national nursing associations from around the world. The nursing profession totals in the region of 20 million folk around the globe, and if you add midwives as well, we're probably talking about 22, 23 million people. And if you just think about that in terms of, there are 23 million nurses and midwives who are out there today meeting patients, having contact with people and communities. If they're each seeing just 2 or 3 people, that's 60 or 80 million opportunities today for health information, for health education, for health advice. And that education advice piece is part of something that all nurses do, indeed all healthcare professionals do. But more than that, we have nurses who are increasingly extending and advancing their roles as well. They may be the first point of contact in the community. They may have taken on a specialist role around a non-communicable disease. There are nurses who are specialists in IPC as well. And then you think on top of that, the locations in which you find nurses, from working on their own in communities, in rural and remote areas where they may be the only healthcare professionals, through obviously to hospital settings, but increasingly working for voluntary or charitable organisations, working in schools, working in the military, working in a whole range of other settings. So in terms of moving forward and getting the job done that we need in relation to AMR, humbly, it ain't going to happen without mobilising and supporting the nursing and midwifery workforce. And the other observation in terms of nursing midwifery, we know from polls that have been done in the UK, in the USA and other countries, nurses have for the last few years rated as the #1 trusted healthcare professional. So the potential there to change attitudes, to change behaviours, people listen and take account of what their nurses and what their midwives say. The other point I think to make is that nurses are involved across the range of administration and management and prescription of medications. For folk who are in hospital and nurses who are overseeing dispensing of medications, but increasingly we know that nurses are, as part of extending their roles, are prescribing medications as well. And if a patient is self-managing but has an NCD, then it's the nurse who is there with them, who is providing advice as to whether they aren't sticking to protocol, taking the full course, self-medicating, stockpiling piles of antibiotics to keep in the cupboard in case they think that they might need them, in the future. I was very grateful to Mark in terms of saying what he did about the importance of the nursing and midwifery professions, and I know that's not the first time he said it. He said that in other public arenas, and I think that's just from our profession's point of view, it's fantastic to see how WHO are recognising the importance of nurses, but I believe all healthcare professionals in a range of work that's happening at the moment. And we have a new Chief Nursing Officer, Elizabeth Iro, at WHO, who's helping us to drive forward the influence of nursing. And my final point would be this, and it picks up on Mark's slide showing the red to yellow move that we saw in the UK, and I was working in the UK over a lot of that period of time. And my personal reflection on that that I'd share with you is that one of the big reasons why that happened, there was really clear nursing leadership from the very top. There's a chief nursing officer who at the time was given lead responsibility by the chief executive of England for taking a lead on MRSA reduction. So you had that lead from the very top, and the woman who did the job at the time, Christine Beasley, was an excellent chief nursing officer. But it permeated right the way down. You had chief nurses in hospitals and in community settings who were taking the lead for their board in terms of changes to clinical practice, but monitoring and surveillance. You had identifiable infection control staff, many of them who were nurses in hospitals and clinics. And you had organisations like the one that I worked for at the time, the Royal College of Nursing, the National Nursing Association, who was providing specialist advice and support. So I think it is a fantastic example of what can be done. Unsurprisingly, I'm making the bid for and pointing out nurses' role in that, but I do think it's key and fundamental.
Thank you to both of you, because with UK you have shown a positive move that we have seen on the slides of Mark Sprenger, though it's possible to do something. And that is, I think, a take-home message here. And it was done by, as you said, by professionals, by moves, by clear collaboration. Now I would like to turn to our next panelist and say, in addition to that, could vaccines help us, and if yes, how?
Thank you very much, and thank you for the invitation to sit on the panel. I'm here as a kind of industry representative, I guess, but my bias is towards vaccines. I'm a vaccine researcher. But I think the first thing to say is that industry wants to be a responsible partner in this. And we've heard already this morning how important collaboration is. None of us in the room or on the panel can do this individually. We need concerted efforts from all parts of the various involved parties and industries, and an important part of that. We've heard about, for example, the development of new antibiotics, the stewardship of existing antibiotics, and there are things that, before reading up in advance of this panel, I hadn't even thought of, thinking about the waste that goes from our manufacturing that may contain antibiotics going into the environment. All of those sorts of things, industry is working to ensure that we contribute strongly to trying to solve this problem. But I think to your specific question about vaccines, I'm absolutely passionate that having worked in the vaccine field for 20 odd years, and I'm sure all of us in the room, the importance of prevention rather than cure is always a primary mantra. Predominantly for bacterial infections, of course, if we can prevent bacterial infections with vaccines, we can prevent people getting ill and therefore requiring antibiotic prescriptions in the first place. And for example, if all children in the world that are eligible for pneumococcal vaccination, which is recommended in many countries, were to receive it, we could save 11 million antibiotic prescription days a year. So the use of existing vaccines, maximising the use of existing vaccines to prevent the infections in the first place, and therefore not require the use of antibiotics, is really an important potential contribution to, I think, to trying to address the problem.
Thank you very much for linking these things together, mentioning prevention. It has already been mentioned by Amanda, I think, that yes, she said, I have diagnostics at hand in my place. And now I will turn to my neighbor and friend Catharina, because she's working with FIND, and my question to her would be, do we need a diagnostic before we prescribe any antibiotics, always?
Not always, certainly, but I think Mark and others highlighted already the critical role of diagnostics in human health, where it's about optimizing the use of antibiotics, but also in animal health, in measuring environmental waste, and areas that often get forgotten, for example, in identifying counterfeits, which is a big problem globally, and in empowering, last not least, surveillance, which is really critically relying on diagnosis in the first place, and where, especially now also in the global health security agenda, in the context of pandemic preparedness, diagnostics that allow us to measure pathogen presence and drug resistance presence is really the basis of a functional surveillance system. So, barriers for diagnostic development and uptake, you've already said it, right? We have some diagnostics, but generally they're not easy enough to use and they're not affordable enough to make it as a first prescription, right? And to get community health workers, nurses, and family doctors to believe that they can and should be using a diagnostic as a first prescription rather than a drug. I do, of course, see important barriers in R&D for new diagnostic solutions. Yes, there are technical challenges and there is a big need, but even more so, I see critical gaps in getting these diagnostic solutions into use once they are available and once CARB-X comes out with tools that have been developed and have made it through the development pipeline. And you've mentioned all that, right? We see in malaria systems that 95 or up to 95% of malaria-negative patients now get prescribed an antibiotic instead of an antimalarial. We see that patients with urinary tract infections are vastly overtreated with sexually transmitted infections. And as we've heard from Mark, often these are not first-line antibiotics, but third-line antibiotics. So we have made some progress in important areas such as tuberculosis, which, as you heard, makes up a third of global drug resistance, where we are getting better in having diagnostics that allow us to identify mutations that enable us to treat with the right antibiotics and the right regimens, but that remains the exception. So where do I see Fine's role in all of this? Yes, we catalyze and support development of new tools, but more importantly, we plan, for example, to very soon launch our first call of proposals, where we are asking countries to apply with implementation partners to propose to us ways in which they can use new diagnostics, existing diagnostics, such as simple CRP tests or emerging multiplex fever panels, and combine that with behavior change packages, education packages, and demonstrate how this can impact and reduce the overuse of antibiotics that we see, for example, when it comes to fever, when it comes to upper respiratory tract infections. We are also very pleased to announce that we've signed yesterday a significant grant with the UK Department of Health on connectivity, diagnostic connectivity to empower surveillance, where we will be working with industry countries, and especially Fleming-funded countries, to basically connect molecular tools, point-of-care diagnostics, with the vision that basically, yes, we have glass today, we're getting a little bit better in surveillance, but what we really need is a real-time surveillance system that allows clinicians to basically act upon new data immediately, that allows WHO to act upon new data. So our vision really is that every diagnostic data point immediately feeds into a data system. And so the important work with GAMRIF from the UK really will, I think, help us to get a big step closer to that. Thank you very much.
Thank you very much. Yes, getting all the information also on all the levels, to the acting clinicians, to the public health level locally, nationally, and at WHO level. I think an important point that you underlined, also for those who are producing something, to be able to judge what is next. Thank you very much for this insight, and I'm turning now to you, to the public, perhaps to you to use this opportunity and to ask questions before I want to have more and more from my panelists whom I ask to. Oh, I see Amanda has.
Maybe while you're collecting your first question, I could just comment about funding of research. So another issue that I think is very important is getting funding for epidemiological work in the community. And that's actually a big gap in lower and middle income countries, which I know WHO again trying to address with partners. But for example, one of the most helpful studies for me was a study done by a fellow GP, family medicine academic, looking at the natural history of febrile viral illnesses. So I can now say confidently to a patient, look, it's common for you to cough for up to 3 weeks, but unless you have this or this or this or a risk factor, obviously each patient is different and we tailor according to their other conditions, prior history, and so on. But you know, that stuff, and you say this is actually how this is going to come through. And so if we don't have the funding coming to do the research in the community, you know, if it all goes into, forgive me, lab or tertiary sector, then we don't understand really what is going on. And I think even more important for those countries that don't have the history of the UK work already, because as Catharina just said, we already have some advantages here, but really let's see some of the research funding going into the countries who have, you know, there's an equity issue there for primary care, but particularly for some of the countries where that's not a common system. Yeah. And without that, surveillance can't happen, right?
Yeah, Catharina.
Absolutely, data are really critical here, and we have data, for example, also from Valérie Dacremont's team from Tanzania and other countries, showing that we can even improve morbidity and mortality of patients if we don't treat them, right? So there is a growing evidence base, and thus we think that this call for proposals for low middle income countries and showing how you can use diagnostics in these countries is so important.
Yeah, I think that the call for epidemiology research also on the very basis shows again the community involvement, because they will be willing to share data if they know where it serves and what it helps to do.
And if you have those skilled professionals in that setting, you know, it helps them to do their work, but it also helps the whole situation to grow. Yeah. If you don't have that primary healthcare team, it doesn't work. Please, audience.
Do I see some comments, some questions? Someone who would like to directly react, Mark? Or I've been yesterday speaking with Professor Pifaretti from Switzerland, from the Ticino. Perhaps he would like to make a comment. Yes? No? No, but we do have Swiss examples too. The country where you are now here does also do its plans, so perhaps if Mark would like to comment on what the panelists said.
No, I couldn't agree more with Amanda, because I think if you look at the data in Europe, 80% of the use of antimicrobials is in primary care. It's not in hospitals. And I think it's very complex because it has to do with incentives. Do you get additional fee if you prescribe antibiotics? This is, in some countries, the case. So we all need to discuss that whole financial system and see how we can make sure that the GP is also a trusted person. And at this time, we discussed the Alma Ata Declaration within the WHO. And that's a long time ago, but I can tell you, look at the Alma Ata Declaration. It's really amazing. It puts the primary health care at the center, but it also refers to agriculture, It's a long time ago. And today we are every day talking about agriculture and the link, in fact, the whole One Health issue. So I would like to support it. And again, nurses do play a role because it depends a little bit on your cultural setting and your country. But in several countries, there is no GP. And I have made a little bit of a mistake that I always advocated you should get only antibiotics on prescription. But in fact, they told me, but Mark, don't you realize that in several countries there is no GP in the vicinity of a patient? There's only a nurse that could be, support a little bit. So that's why we would like to pay much more attention from WHO side to the nurses and midwives.
Thank you, Mark. If you could give the microphone directly behind, I saw that. Yes.
Thank you very much. I want to just share in the dose briefly. Yeah, my name is Joanne Mazet. I'm former NGOs Coordination Officer in the UN, and I'm still involved with NGOs following international organizations, including on health. Yes, Almata, WHO. Recently, the yearly tripartite meeting between WHO, WTO, World Trade Organization, WIPO, World Intellectual Property Organization, we dedicated that on AMR. Yeah, what I wanted to share with you, with those what we said in the UN, in the international area, observers, organizations, in WHO, like we have here the expert audience, International Federation, European Federation, European Society, Council. Yes, it is observer statute, but it is not a passive statute, it is an active statute, because your recommendations, your expertise during the meetings are very useful for government, are complement for government. This is what I want to share, that we have the challenge nowadays is with the facing globalization's challenges. Yeah, this is what I said, in global area, how the international trade could be not really a barrier to achieve public health, to guarantee public health in the worldwide level. Thank you very much.
Yeah, thank you for alluding the global aspect and the fact that we clearly have to see the global picture also as a civil society, as well as the nation states and their organizations. I think this is also one of the reasons that we are in this area, in this place here in Geneva, because here we can really meet between all the layers. And unfortunately, I'm already at the end of this panel. I would have loved to continue and give you more, but I think it is again time to give a standing ovation to the panelists.